Hello, welcome everybody to the CMS Emergency Preparedness Rule webinar series. Today we have part 1, Building Your Emergency Preparedness Program. We're here today with Jason Belden, Disaster Preparedness Program Manager, and Courtney Kesterson, Disaster Preparedness Program Coordinator. If you have any questions during today's presentation, please use the Questions tab. We're going to take about 10 minutes at the end of the presentation to answer as many of your questions as we can get to. All right, so without further ado, here's Jason.
Thank you very much, Casey. And good morning to everybody that's on the line with us today. Like Casey said, we're going to have a 4-part webinar series to discuss the full CMS Emergency Preparedness Rule. Part 1, we're going to concentrate on the first component of the rule, and the remainder of the webinars will follow kind of how the rule is laid out from CMS. And so today we're going to talk about, kind of how CMS came to do this rule, and then talk about the first component of the rule. So in 2013, CMS submitted for public comment a set of proposed regulations requiring 17 different healthcare provider types to have an emergency preparedness program. 3 years later, they promulgated the rules effective November 15th of 2016 with the November 15th of 2017 implementation date. And really the reason why CMS thought this was important was in reference to a number of large-scale disasters or catastrophes that had severely negative negative outcomes for healthcare facilities, specifically Superstorm Sandy and Hurricane Katrina. So in the original rule, CMS said that they currently think that in the event of a disaster, healthcare facilities across the nation are not prepared. They don't have the necessary emergency planning, and they're not prepared to adequately protect the health and safety of their patients and or residents. So what that basically means in translation is that after CMS looked at the existing disaster plans for a broad swath of facilities across the nation, they found that most, if not all of them, failed in being able to protect their residents in the event of an actual emergency. So that's why they came to the decision to pass a basic set of rules. So what is, why is CMS, passing the rule? We've kind of talked about that. The existing plans were insufficient. So with that being said, in November of 2015, hopefully you guys are aware of this, and if you're not, all of the elements that we're going to discuss in all of the webinar series need to be implemented by that date in November. So your emergency preparedness program needs to be fully completed by that date. It doesn't really matter when your survey is going to be. So you may be surveyed in, let's say, April of next year. Your documentation for proof that you've completed all this element needs to show that it was done prior to November 15th of 2017. So, that includes the training and testing portion of the program, the emergency operations plan, the HVA, policies and procedures, all of those things like that. So we'll get to all of those levels of the rule in other webinar series, but we're just going to specifically talk about the first part of it now. So let's go to the next slide. Oh, so let's before we go to the beginning of it, can we get I just want to get an answer from folks. If you guys have been to any emergency preparedness training on this new rule, please answer yes or no. So, and it looks like we've got about maybe a 60-40 split. So about 60% of folks have not gone through this rule, so, or at least received training on the rule. So for the 40% of you guys that have done an emergency preparedness training on this rule, we're going to repeat some of the stuff you probably already heard before, and we're going to dive a little bit deeper into the elements that are required in the first part of the program. So let's go to the next slide. So when CMS says emergency preparedness program, let's talk about what that entails. So in the emergency preparedness program, you have a number of different components to that. So the emergency preparedness program contains risk or hazard vulnerability assessment, or risk assessment, or risk analysis. There are a number of terms for this. They're all synonymous for the same thing. In the CMS, a lot of the documents that CMS has sent out in terms of guidance, they call it a risk assessment. In the emergency management world, it's called a hazard vulnerability assessment. The two terms are synonymous. And then from that risk assessment, you get these other categories. You get continuity of operations, and we're going to discuss that a little later on in this particular webinar. An emergency operations plan, which we'll cover in a moment. The training and testing program, which will be our second webinar series, and the policies and procedures that need to be in the emergency operations plan. So those policies and procedures for intermediate care facilities and skilled nursing facilities are a little bit different than the other provider types, very similar to an acute care hospital. But in the third webinar series, we'll talk about policies and procedures, because there are a number of things for skilled nursing facilities and intermediate care facilities that we need to consider. So let's go to the next slide. And so if you look at it in terms of a pyramid, Courtney's going to kind of talk about how each thing influences each other, and then we'll go from there.
Hi everybody. My name is Courtney Kesterson. I'm the DPP coordinator. So what you're looking at right here is a pyramid that kind of shows the relationship between some of the things we're going to talk about today and in our later webinars. So really, where do you begin with preparing your preparedness program? CMS wants everything based on a hazard or risk vulnerability assessment, like Jason mentioned. And so everything kind of builds on top of that, and we'll refer back to the HVA as we call it, but that's still, a risk assessment where you look at the different hazards your facility will be facing. So CMS talks about using an all hazards approach when you're creating your emergency preparedness program, and you use the risk assessment or HVA to approach this. The HVA helps you take into account all of the different factors you might have to contend with, and it also prepares you to it helps you prepare your critical functions during an emergency. So you might be preparing for an earthquake, but those skills and those functions that you're drilling on will really prepare you for all sorts of different hazards. The other part of this is that your HVA is very much tied to your location. As you'll see, we'll talk about how you might be affected by an earthquake or a tsunami, so knowing where and what your local threats are is a large part of this next section. So as I mentioned, you're faced with a lot of different hazards, and on a risk assessment, we typically break them up into what's known as natural hazards. You can see here earthquake, flooding, fire. And then another section you might see would be man-made hazards, and this would be anything from active shooter to a train wreck, polluted water, etc. And so the first step to completing your HVA is to get to know your own backyard, basically. You'll need to reach out to maybe your local fire department or city officials to see if they've already done a hazard program or hazard assessment for your area. Or you can type in your address at this link here that we've posted at Cal OES.
And so also, and for folks in California, a lot of this information can be found at the local level, meaning your county offices of emergency services, possibly the county hospital preparedness program coordinator can point you in the right direction. Also, if you have an acute care hospital partner that's Joint Commission certified, chances are they have already completed an HVA that will incorporate not just the the natural hazards that could possibly affect your location, but also the man-made hazards in your area that you might not be aware of. Things like railroad crossings or manufacturing facilities where it could present a risk in your general area. How close you are to major transportation hubs. There are a number of things that when you have to consider that. So that mapping software that's put out by Cal OES, I'm not certain if it works in every state. I think that is California specific, but all you have to do is put in an address, a zip code, a city. You'll get an idea. And even though this picture here shows Sacramento, we're not particularly big on earthquake risks. In other locations, you'll see a varying degree of different things like flood risk, a scope and severity of fire risk, tsunami areas, obviously if you're coastal, liquefaction areas. So if you're in an earthquake zone, how likely is it for the ground to move significantly? So the next picture shows a couple of those areas that are coastal and that are both earthquake-prone areas, Long Beach and San Francisco. So it's a great tool to use to discover your natural hazards. But when it comes to the man-made hazards, I highly recommend getting plugged in with that Healthcare Coalition. Maybe those folks can point you in the right direction, but the County Office of Emergency Services has a plan that they've already based on a risk assessment, and I would ask those folks if they could share those risks with you so you can build your HVA.
Right. And so if you look at the slide here, we have these maps, and they have these purple lines on them. So we can use this as an example. Imagine if your facility was sitting on top of a fault line. That would put earthquake as one of your most extreme risks. Whereas if you are in an area where that might not be as big of a factor, kind of just depending on the ground underneath you, that would be something that you would take into account in the risk assessment. And so just so you can kind of see what kind of tools you can use for this risk assessment. On the right, we have a tool that was put out by Kaiser Permanente. So this is created for hospitals. It's kind of known as the gold standard for hazard vulnerability assessments. But on the left here, we have one that we'll be using today. It's a little bit easier to work with, just to show as an example. Both of these and a few other options are available on our website, and you can see the link down there in the corner. CAFDisasterPrep.com is where all of our resources live right now. So let's take a look at how to actually fill out one of these. So the first step here, we already kind of looked into our community's hazards while we were talking about man-made and natural hazards. The next thing you would want to do is gather together the department leaders from your facility. And this is kind of where you would start looking at your continuity of operations. You need to be asking them what kind of challenges would they be facing if some kind of event were to occur. What would their priorities be? Or could you even assign them somewhere else that's a higher priority?
Yeah, I think that what we would recommend is if you have a team within your facility that represents a department leader from each department, folks like dietary and housekeeping and obviously nursing, maintenance, things like that. You want to be polling these folks and asking them, in the event of this type of hazard or emergency, let's say earthquake, for example, how would your operations for your department be impacted? Would there be a significant stopping point for the work that you do, or would you be able to carry on as usual? There may be hazards that you identify as being a risk, but maybe that doesn't pose a problem for the folks in your maintenance department. Maybe, let's say it's an exterior vegetation fire, but the folks in your maintenance department say we can close all our fresh air intakes so we can make sure that we protect our residents from smoke and things like that. So, it's important to ask them those questions after you've identified what the most likely hazards are. You could say, in this case, how prepared is your department to continue to operate in that type of an emergency? So, and that will lead to one of the scoring factors that we'll talk about on the next slide.
Right. So the third step is what we're going to be doing next. We're going to be analyzing and scoring your specific hazards, and that will help narrow down where you want to focus on training your staff. So here we have an example of the HVA. This is actually available as a handout under the Handouts tab, and this was also emailed out to you at around 9:30 today. I know that we had some late signups though, so this is also under the Handouts tab. And so moving on, you may have seen the...
So can we go back to that slide, Courtney, please?
Yep.
So let's go back one more slide, sorry. So we talked about, getting to analyzing the critical systems related to your top 3 to 5 hazards. So once you do all of that, when you do your HVA, this is also going to, we're not talking about the training in this webinar, but it's important to note that all of these things influence what you should be training your staff on for emergency preparedness. And that's not just a best practice. That's something that CMS has said in the interpretive guidance, that you want to use your HVA to dictate what you should be training your staff to deal with. So if you have identified earthquake as a major risk, then how you deal with an earthquake needs to be in your staff's training kind of program. And when we talk about the testing requirements, that should be influential in what you do for testing in your program. And then all of those things lead back to the last thing, which is mitigation. And Courtney's going to talk about things that you can do to do mitigation that would potentially reduce the score on the HVA. So if you go to the next slide. On the HVA, it's important to note that this is a relatively simple form. This can be done in 20 or 25 minutes, maybe 30 minutes, if you have the information. It does not take very long. Obviously, if you're in Southern California, you can put zeros in for a number of these things. If you're in Northern California, depending on where, it's still unlikely that snowfall or blizzard or an ice storm are going to be a realistic scenario. So if that's the case, you just answer none. And the easiest way to think of this is, probability times risk times preparedness will give you your score. And I think we have the next slide. We'll talk about that.
So those scores at the top of the HVA, you can think of them as defined in the following. So like Jason said, if it doesn't apply to you, you can put a 0. As far as risk goes, for something like a major earthquake like down in LA, you would put a 5, something that would threaten the health and safety of your residents. And if you don't know whether you should put a 4 or a 5, Well, we want to be preparing for the worst case scenario. So we say to round up if you're not sure.
Yes.
It's always better to be more prepared than to underestimate yourself.
Yeah, and CMS just did a webinar or a in-person training for surveyors, I believe yesterday or the day before, and they made it very clear to tell the surveyors, the people that are going to be doing these surveys, that always err on the cautious side. So prepare for the absolute worst. A number of us, if you live in California, it's more likely than not you have been through an earthquake. And it's more likely than not that earthquake has not presented a very big hindrance to the way you operate. There are obviously Loma Prieta and Northridge obviously had huge effects, but the majority of earthquakes go right. They're very minimal, maybe a little rattling, but that doesn't mean that an earthquake couldn't pose a life safety threat. So always err on the side of caution with that, because as you prepare, you want to prepare for the worst, and if it's not that bad, then you are over prepared. But if you prepare for just a minor disruption and
the big one hits,
you're not going to have the preparedness in your plans to deal with that kind of issue. And you won't have concentrated on training your staff and making sure your policies and procedures are built to deal with that type of an emergency. So.
Right. So we're about to walk you through how to kind of do the math on this, so to speak. So we'll keep going here. Here's our form again. So if you were to fill this out, some things that you might kind of ask or say to yourself is, we've identified earthquakes as our largest hazard. So then for that, you would give yourself a 3, which is the highest score for probability there. We have determined that this earthquake could be a threat to life and safety. So we would give that the highest score there as well. And then for preparedness, we have not done any kind of training at all. We would give that a 3 for poor. And then you multiply those across with our formula up there, and it would give you a 45. So that's about as high as it can go. That would be one of your top 3 to 5 hazards that you would want to focus on. So we talked about being prepared, and so with something like maybe a wildfire, there are some things you can do to kind of mitigate or prepare for and kind of negate the effects of some of these hazards. So we have some examples here, such as fire lines or creating a protective area around your building by clearing brush for 100 feet. We have this great picture here of this guy who put up an inflatable wall around his house to keep the floodwater out. But some more examples here would be using fire-resistant materials or strapping down a water heater.
So and it's important to note that mitigation is not just something that you can do physically to your building to prepare it for an emergency event. There are things that we don't even think about that are mitigation measures. Stuff like earthquake strapping on a hot water heater, or making sure your generator is seismically certified, or the HVAC unit that goes up on your roof is not going to come down in the event of an earthquake. There are things like that, cutting fire line. But it's also important to note that training your staff and having robust policies and procedures in preparing for these events also acts as a mitigation measure. So in the HVA that we talked about, it scored, 1 through 3, basically, whether you were prepared, how you viewed your preparedness. And poor would be an example, let's say if you identified earthquake as a risk, you had not done earthquake drills, you didn't have earthquake strapping or seismically certified HVAC units on your roof. Things like that would all lead to a poor score. But let's say you had done those. You have earthquake strapping, you have seismically certified equipment that's connected to your building, you have trained your staff on how to do how to act with an earthquake. and you have policies for your maintenance personnel to go out and check the building after an earthquake happens. All those things lead to a reduction in that score. So that would lower your risk and maybe potentially take you away from needing to concentrate on that once you had, a good program set up in terms of training and the physical plant requirements for some of that stuff. So
right, and when you actually find ways to mitigate some of these events, you can change that on your score on this HVA. And this is important because CMS is requiring you to annually update your plan and annually update your risk assessment. So your probability and risk columns probably would not change, but your preparedness can. And that's where you'll see kind of the improvements in your training and testing programs. Okay, so now that you've completed your HVA, the next step, what kind of gets built on top of that, now that we know your top 3 to 5 hazards, is the emergency operations plan. So CMS is requiring that your emergency operations plan address the unique needs of your population, and we'll cover that in a little bit. Have strategies to address events indicated by your risk assessment, and we will go in depth in that a little bit more in one of our later webinars. Identifying services that must be provided in the emergency. We'll connect back to that later. Identifying services that must be provided in the emergency and continuity of operations. So CMS is not requiring you to have a BCOOP plan, but they are referencing it, and your plan will need to have some kind of contingency for continuity of operations. And then you'll also need to have some kind of plan in your EOP for cooperating with community and emergency responders. So here we have our first set of survey procedures that we've gotten from the interpretive guidelines, and Jason is going to review those really quickly.
Sure. So the surveyors, it's a lot of this stuff, and it's important to note that if you guys choose a off-the-shelf product, if you use the EOP template that we designed for Los Angeles County, you're welcome to use any of those things. There is no requirement for using a specific format in coming up with your emergency operations plan. There's no requirement for doing a specific HVA, but you need to be able to prove that you have countered in all of these specific things, like where your facility is located, like the types of folks you have in your facility, and how are they addressed in the event of an emergency, and why they were included. And I think we have a couple slides on that in a second.
Right. And also, if you look under the handouts tab, there is a 4-page document that is part of a larger checklist, and this will help you kind of go through maybe your existing operations plan and see if you have these elements that CMS is looking for.
Yeah, so there are a number of off-the-shelf products that that have been designed to be compliant with this new rule. I don't want to list them out, but if you have questions about where you can find something that's not a CAF document, email me at the end of the program and we'll talk about that. And like Courtney said, that risk assessment, has to show that you viewed all hazards, natural and man-made, and it's specific to your geographic location. And you need to update that, or at least, let's say your EOP, you write this big, long emergency operations plan, you do your HVA. You don't have to rewrite it every year, but you have to review it every year and provide proof to the surveyor that you have done that each and every year. And once you do that, theoretically, through your training and testing program, you will learn about maybe some deficiencies you have in your emergency operations plan, and you can update it then. So there's a combination of ways that you can lead to updating your plan.
And if you go to this link here that you see on the screen, That's where you can find this template. You can also find documents like review logs to help you track when's the last time you updated it, and that would be perfect to show a surveyor.
Yeah, and so that in regards to the template, we designed this template prior to the rule being implemented, and it contains all of the minimal required elements. We would still like to tweak it some, so we're redoing the emergency operations plan. One of the main reasons is our current template now suggests that each person that's using this template is also using incident command within their facility, so the nursing home incident command system. Not everybody uses that in their facility, and it's not a requirement by CMS, but I will tell you, in the event of an emergency, there is a reason why every emergency department, every emergency services in the state of California uses incident command. So fire departments, police departments, county and state OES, Department of Public Health, everybody you can think of uses incident command. And so if it's a debate on whether you do it or not, my recommendation is learn incident command. If you want to go to a training, we're offering a free training next month in October in Los Angeles. You can ask us about how you want to attend that. It'll be an in-person meeting, and of course it's free of charge as well. But that EOP template references incident command numerous times. So if you're going to use our template and you're not going to do incident command, you need to make sure you remove all those references from the template, because the first thing the surveyor is going to do after they look at this is, and it references incident command, they're going to ask you, okay, who's incident commander? And what happens if that person's not here? Who assumes incident command? And who's your operations chief? And who's your, they'll ask these questions, and if you haven't implemented it, you won't be able to answer those questions. So.
Right, so the CMS rule, it does refer to the need for staff assignments during an incident, but it does not specifically say that you have to use incident command or nursing home incident command. So it's something to think about. This would be a good tool for you to meet that requirement, but again, you can make up your own version of staff assignments. It is good though, because if there's an area-wide disaster, you plug right in with all of the other response agencies because everybody's speaking the same language. Okay, moving on. So the next important part of building your EOP, CMS wants it to address your population's unique needs. So with skilled nursing facilities, we get a lot of residents who are non-ambulatory. So if you think about an evacuation scenario, what kind of transport are they going to need? What kind of unique things about them will they need in order to go to a new location and still receive the same quality of care?
Yeah, and so we might have some folks from the ICF community on here. For your folks, it's cognitive disabilities, or in the event of an evacuation, or whether it's an internal fire or something like that, are they able to respond to verbal commands? Do they require assistance in evacuation? Things like that are things that need to be addressed in your emergency operations plan. And CMS has made this clear. I think they reference unique needs, like 50 times during the rule. So this is one of their real big areas of focus. So, and when the surveyor comes to your facility and talks to the administrator, they're going to want to hear how you accommodated that in your plan. So, and we've got this list of just kind of common things. Courtney, is there anything else on there that you wanted to talk about? So
no. So we have our next slide, which would be the survey procedures. What are the surveyors going to ask you to prove that you've thought about your residents' unique needs?
Yeah, so Courtney made a great point about the transportation resources. In the surveyor is going to come in and ask you, how does your plan accommodate the folks that you have identified as having unique needs. And unique needs means unique needs in terms of a normal a person walking down the street. So it's not unique it just means that the folks that you have in your building have certain common problems. Non-ambulatory dementia, if you have bariatric patients, folks on ventilators, if you have a subacute facility, all of those things, you could have folks with loss of eyesight or deaf or a combination of a bunch of things, folks with DME requirements like oxygen dependency. All of those things have to be in the plan, have to be accommodated for in the plan. And so one of the first things the surveyor is going to ask is, how did you accommodate that in your plan, and how will those folks be affected in an emergency, and how are you going to deal with that? So that's going to be one of the main areas of focus that the surveyors are going to focus on. And then the surveyors are going to ask, what services have you identified that you will provide during an emergency? And obviously patient care or resident care is one of them. And that ties into how is the facility going to continue to operate during an emergency, because just because an event happens does not mean you stop and close up shop. That's not what we can do. Even if you evacuate, you still have to continue operations. We had a number of facilities evacuate in Butte County and Glenn County and Yuba County. And those facilities did not discharge their residents. Their residents were temporarily located in other places. So they had to track where those residents were. They had to do that. And so they're still billing whoever whether it's Medi-Cal or Medicare or private pay or whatever, they're still billing for those services, even though the folks are not located in their facility. So your plans must have a contingency for that.
Right. Jason made a really great point. This is kind of where your residents' unique needs and your continuity of operations intersect. So CMS, they want you to, part of identifying your residents' unique needs in an evacuation would be finding like facilities for them to go to. They need to go somewhere where they're going to receive the same level of care. So you need to have these agreements beforehand, and that also connects back to your continuity of operations, because if you don't follow those guidelines, getting reimbursed from Medi-Cal, Medicare is not likely.
Yeah, what we learned in that event, in the Oroville event, was that facilities that transferred their residents to general population shelters rather than transferring their residents to another skilled nursing facility, is they will not be reimbursed for the transportation costs. So, so that's an issue, and in the policies and procedures section of the webinar, we'll talk about specifically what's required for your evacuation policy and what must be included. But that's one of those things is that they point out is that you must find a like facility to get your folks to. So, and then the last thing is they want to see a written procedure for delegation of authority and succession planning if the administrator is your identified incident commander or identified as your leader during an emergency event. If something happens to them, either during the event or they're not available. We had in San Diego during the fires in 2007, there were a number of administrators that were on an out of the country training trip with facilities in Russia, and so the fire happened, and I'd have to get clarification, but I think it was like a dozen administrators from facilities in San Diego County were out of the county when the emergency happened. So who will be in charge when that happens? So.
And so when it says delegations of authority and succession plan, that would be right where the nursing home incident command system would fit the bill there. But again, CMS isn't requiring you to use NHICS.
So let's hop right into, we had mentioned earlier about coordinating with local emergency responders. So this is called out in the rule, and it says you must, in your emergency operations plan, have a process for ensuring cooperation with your local emergency officials. And that, for most of us in California, will be the county. All kind of response either resides within the city or the county. But mostly, in most places, it will be the county. So, it's a requirement that shows that you have collaborated with those folks in order to understand what the response mechanism is in the case of emergency. So, and then obviously with any survey procedure, you need to have documentation of your effort to contact those officials, and if you're going to, if you're active with your healthcare coalition, we'll talk about what that means in a second. But keeping agenda items from the coalition meetings, keeping sign-in sheets showing you've attended, all of those are going to be integral to helping you pass the survey portion of the thing. So the surveyors are going to ask you how you did that. Do you have, are you attending those healthcare coalition meetings? Who is going to be the one that helps you with transportation resources in the event of an evacuation? Or who can provide you with resources in the event you cannot find, medication? Let's say, you are forced to shelter in place due to a large emergency event. Who are you going to call to help you fill those resource needs? And so those are things that the county is set up to deal with, and those folks need to be, you need to cooperate and collaborate with those folks early and often. And then the surveyor is obviously going to ask for documentation of that stuff. So that's why we want you guys to keep the agendas from those healthcare coalition meetings and sign-in sheets showing that you've actually attended. Now, this is an interesting part of the rule that may or may not apply to you folks, but this deals with folks that are part of a distinct part skilled nursing facility, or maybe part of a chain of nursing homes that wants to do a integrated emergency preparedness program that incorporates all of the facilities. You can do that, and CMS has said that you can share in the development of those emergency plans, but it's the list of requirements on the interpretive guidance, if you want to do that, is pretty lengthy. So in essence, what happens is if you're a distinct part SNF, or if you're a corporation and you're trying to do a central emergency plan that would incorporate everybody, each facility needs to be included in the development of that emergency operations plan. And you need to document that each facility had their voice heard in the development of those plans. And that is, it says it explicitly in the interpretive guidance that there needs to be proof that each facility, their specific and unique needs were met, and that the risk assessment was done knowing the hazards that they face in that location. So it makes it really difficult if you're in, let's say you're a company or a corporate chain and you have locations all over the state of California. If that's the case, it's going to be really difficult for you to come up with one plan that's going to be effective for everybody. So just keep that in mind. There are a number of rules within the, or a number of things within the interpretive guidance that you guys have to take a look at before you decide to do that. So we talked about healthcare coalitions. CMS has not said they mandate you participate in your healthcare coalition, but they're highly recommending it. And the things that they're asking you to do in terms of collaboration with your local jurisdiction, these are the easiest ways to meet that requirement. So if you have not joined your local healthcare coalition, please start on that process now. Most of them meet like quarterly, so 4 times a year. If you're in a large county, there's obviously not going to be a way for them to accommodate all of us. Like Los Angeles County, if you guys all showed up to a healthcare coalition meeting, that would be 400 skilled nursing facilities just in the county alone. So what we recommend doing is, in the instance of Los Angeles County, CAF attends those events, and we will have a bi-monthly call to discuss information that's passed out that's relevant to emergency planning for CMS, the CMS rule, and we will also give you the agenda items and all that stuff for all of the meetings. So in Los Angeles County, it's broken up into what's called DRCs, but in other counties, it's just one central coalition. If you have questions about how to get a hold of your county healthcare coalition, or who the folks are that run that coalition, email us privately, offline. We are working on building a complete list for the entire state, so every county will be represented.
And that will be on our website, so you can also check back on our website, cafdisasterprep.com.
Yeah, and so, and these are the folks that will be organizing the community-based exercises that you're required to participate in, and they'll help you build that relationship with those folks that will be your emergency contacts, because you don't want to be meeting those folks for the first time during a disaster. You want to meet these folks that are going to be helping you in the preparedness or in the planning stage of your emergency plan. So we talked about the facility leadership is going to be asked to describe your process for ensuring cooperation. So that means you'll need to be able to verbalize that you're a part of your healthcare coalition, that you go to the meetings, that the coalition is planning an exercise, and this is the date we're going to participate with them. And then the surveyors are going to ask for that documentation during survey. So we have referenced the continuity of operations plan. We have a template that's available. I want you to know this is not the end-all be-all of templates for business continuity plans. There are literally thousands of free resources on the internet that are available. There are some you may see that say HSEEP, H-S-E-E-P, HSEEP business continuity plans. You can certainly use those, but frankly, they're going to be overkill. They're probably, like a 100-page document. It's just incredibly complex to do. The template that we have on our website is significantly easier than that. And these are some of the things that need to be included in a continuity plan. You need to identify essential personnel and the functions that they will provide during the event of an emergency. We've talked about this ad nauseum, but orders of succession and delegations of authority in case the administrator is not there or cannot be gotten hold of, or the owner or whoever is the identified leader. Resources that are critical to your operations, vital records, and data protection. How are you going to share electronic health records and patient data with, or resident data with another facility should you need to evacuate. Pre-identified evacuation locations and continuity of communications if you lose primary communications. There are other elements of the rule that has specific requirements for primary and alternate means of communication, and we'll talk about that at length in in the third webinar. But all of those things are contained in our template there. But they must contain all of those items for a true continuity of operations plan. Wrapping up, I know we covered a lot of stuff. And for those of you that have not heard this emergency preparedness program or rule before, it's way more complex than it initially, or way less complex than it initially sounds. And I realize that for folks that don't do this, this is going to come as a big shock. But there's nothing in here that's like calculus or statistics.
It's a lot of common sense.
Right. It's thinking about whether you've been through an event before, how will your folks act? All of these things will help you realize it. You know your business better than anybody else. And just think about all of those things that could be impacted, and then build a plan to deal with that. So we talked about in this review today, we talked about why CMS came up with the rule, what goes into the entire program, how to do your HVA, how to base your emergency operations plan on your residents' needs, who you need to be working with in an incident, and how to do a multi-chain or organization's existing policies, and why you need to get involved in your healthcare coalition. I will also say that we have a number of free resources that are available. Courtney and I are available for your questions at any time. If you have site-specific stuff that you want us to answer questions on, please send us an email privately, and we'll be happy to help you out. So do we have any questions on the...
Also, under your handouts, we have a summary of the entire rule with a lot more of these links too. And we'll be referring back to that during our other webinars. So that is kind of the syllabus really for this whole series. Questions? Sorry, we're just taking a look at the...
So it looks like we've got a number of questions here.
Here we go. All right.
All right. So one of the questions was, CMS appears to be focusing on just SNFs, but we are part of a multi-level or CCRC. It seems that it would be wise to have a campus-wide plan. And so that's what we, in that integrate, or in the allowance for having a full plan for all of the facility, that is 100% not only allowable, but we would highly recommend that. So in that event, as long as the skilled nursing facility has their needs specifically talked about in your emergency operations plan, there's no reason why you couldn't have the plan be also for your assisted living, also for your independent living, also for your memory care if you had it. When we talk about an emergency plan, it's usually based on the capabilities of your staff and your facility, and not necessarily, just for each individual disaster. So, it's important that if you have a CCRC, that they help you out in terms of developing the plan, because you may not need to evacuate. Maybe there are places within your facility that you can move folks to. You would have to ask, licensing and get pre-approval to do a lateral evacuation to your assisted living. But as long as you could provide that you could, do the same services in that building, I think that would be allowable. But that's up to the surveyors. So, and I had another question that said the HVAs I'm familiar with the HVAs from FEMA training, and it was brought up as something essential, not a requirement for SNF. And I just, if we didn't make that clear, you will need to provide a copy of your HVA and explain to the surveyors how you developed the HVA, how you weighed each risk. That is a part of the survey procedures. That's what the surveyors will be trained on. They will be looking at specifically, not just that you've done it annually, and that and how you came up to decide those. So, so that's important. I had another question that asked, SNFs prior to this were required to provide fire and disaster manuals. Does an EOP substitute this or complement it? So the fire manual should stay the fire manual. That is separate. The disaster manual you had will influence the design of your emergency operations plan. And so once you complete your EOP, if you have not done it, you can discard your disaster manual, because all of the elements within that disaster manual should be contained within your EOP. So, which one?
Let's scroll down here.
So somebody was asking a question about a community and disaster drill. That's going to be in the next webinar next Wednesday. But I will say just quickly, that is a requirement to do the disaster drill or disaster exercise with a community-based exercise by that November 15th date. We'll give you specifics next week if you tune in, and that's probably going to be the most time-consuming portion of getting this fixed. So in establishing emergency transfer agreements with same level of care facilities, is there a recommended distance away from the disaster site? That is a great point. So if you're an independent owned facility and you don't have sister facilities, then what we would recommend is when you're doing those MOUs or agreements with other facilities about reciprocal transfer of residents during evacuation, we would recommend having a number of facilities both near and far. So having agreements with 5 or 10 facilities locally, and then maybe having some that are farther away, maybe could be outside of the affected area. So in the event where the folks that were affected by Orville, those you got 5 facilities being evacuated. That's literally hundreds of residents. At our current occupancy rates across the state, there's no way we're going to transform to 1, 2, 3, 4, 5 different facilities. They went to literally like 50 or 60 different facilities. So when you develop those transfer agreements, keep that in mind. Do both near and far. If you're in a county with where they do better at electronic bed polling, a lot of that stuff can be done through electronic means. So if you're in Los Angeles County, the county pays for you to sign up for ReadyNet. And ReadyNet is an electronic bed polling system and a resource request system that is overseen by the county, and it helps them kind of figure out where folks need to go in a large event or a disaster. But it can be something as simple as a single event in a facility. You call the county and say, we need to evacuate. We've had power failure that affected our generator, and we can't run our generator. So we have no power in the building. We need to evacuate. Now, nobody else is affected by that. The county can poll different facilities using that ReadyNet software and say, who has how many beds, and are they male residents? Are they female residents? Can they go either sex? Do they have specific medical requirements? So in certain counties, they have that. Sacramento County, some of the Bay Area counties, San Diego County, Santa Barbara County, those counties have those systems. It's either ReadyNet or EM Resource. If you have questions on whether your county provides those services, the Healthcare Coalition obviously can answer those questions, but you can email me or Courtney, and we can look that up for you. So there was another question: do we need HVAs as well as the risk assessment mentioned in NFPA 99? And so yes, these are two different things. The NFPA 99 risk assessment is only for life safety code. This risk assessment that's mentioned is for emergency preparedness. So you will still need to do both things. So, what's the next one? How does a SNF that is inside a critical access hospital, can these plans be tied together? And yes, they can. So as long as the SNF is at the table during the development of the emergency operations plan, and that the unique needs that are that your residents have versus the folks in the hospital are addressed in the emergency operations plan, you are more than welcome to share in the development and design and have one integrated plan. So if a facility is closed due to a disaster and residents are transferred to another facility, are staff allowed for follow and care for those patients? Absolutely. And so that is going to be one of those things that you need to accommodate for. In the rule, CMS has said that not only must you track residents in the event of an evacuation, but you need to track staff and where the on-duty staff are. You don't have to track them when they go home, but on-duty staff. So, and it's expected if you, let's say you're sending 10 folks to one building, you should be sending the resources to help that other facility deal with those 10 folks that they're getting.
The nursing hour ratio is
Right.
not waived during a disaster.
Yeah, licensing will not waive the nurse ratio during disaster. So 3.2 now, soon to be 3.5. They won't waive those requirements. So you need to be sending staff with folks when you evacuate them. So
Let's see, next question. Sorry, we got some more popping up here.
So we've got a question of, they have 10 ICF facilities. Do we need 10 separate HVAs? Even if 3 of the homes are located within 1 mile of each other, I would say, each HVA should probably have it's the name of the individual facility on it, but obviously for those 3 homes, it's more than likely that the hazard vulnerability assessment will be identical for each 3. It's hard to say. Technically, the rule says each one has to be done by itself, but if you're that close to each other, you're probably going to share the same information. But in your emergency operations plan, it's going to have to be unique to that facility. So even if it shows the same data, make sure it's on its letterhead of that particular facility. And that way you protect yourself from having a surveyor say, well, you didn't do the HVA. So we want to avoid that. So we got a next. So yes, we got another question. Sorry, did you just say the staffing requirements will not be waived during a disaster? According to CMS, this is straight from licensing. Nursing hours or staffing ratios will not be waived in the event of an emergency. So that one is okay. So and this, if we didn't make this clear, I apologize. But all of the tools that we developed, the templates, the free resources that are available on our website are for members and non-members. We do all of our stuff. We do that through a grant, so it's available to anybody for free. And if we're running out of a specific time, but if I'll answer one more question at the very end there. It says, owner is very involved in operations. Can he be the incident commander via phone, or does the IC have to be on site? Well, that's certainly up to you. As a part of a best practice, we would say the incident commander needs to be there. But there's nothing within the rule itself to be compliant that says if you're incident commander, you couldn't do it by phone. In incident command, it's very scalable. So you have, you could have a really small event where you do incident command or activate incident command in your facility, where you do that from by phone. But if it's a large emergency event, you need to be on site as a matter of best practice. But as far as the rules concerned, there's no requirement for you to do that, only for you to be able to prove that you can provide each one of those services in the event of a disaster. So So I know there are still a number of other questions. If I did not get to your question, Courtney or myself will be happy to answer them. Please send us a private message. And remember to fill out, if you need continuing education credits, remember to fill out the evaluation form. And hopefully we will see you guys next week. And this has been recorded, so if you missed a portion of it, you want to go back to it, we will have it up on the CAF website, and we will also put it on the CAF YouTube account.
Right. Just a quick note. Our next webinar is next Wednesday at the same time, 10 a.m. Pacific Standard Time. We'll be covering the testing and training portion of the CMS rule. We want to get this out there before you actually have to comply with this, so that you have time to try and do a training or a testing exercise. About the evaluations, if you click the button on the bottom of the form after you've filled it out, it automatically emails to me. You don't need to download the form, or you can and do it the old-fashioned way, whichever way you like, but I did try to make it easy. Yeah, if you have any more questions, go ahead and email me at ckesterson@caf.org or jason@jbelden@caf.org, and I'll make sure that those emails get to you as well, so that you know exactly who to message. One more thing, we're grant funded, so all of this is available to the public free of charge, and if you have any questions, let us know. Thank you for joining us today, and we will see you next week.